Hello, thank you for joining the virtual workshop on health living with HIV 2020. My name is Sendaula Emmanuel and I am presenting HIV treatment in elderly women, looking at experiences, unique challenges, and lessons learned. In Uganda, we have seen great successes attributed to antiretroviral therapy towards the improvement of the health status among the people living with HIV. However, in the same country, we've noticed that strategic frameworks for coordination and implementation of HIV interventions have not targeted older populations. Yet this population has played a frontline role by looking after orphans and vulnerable children left behind by the youth who have succumbed to HIV. We well understand that elderly women living with HIV face not only medical problems, but also social problems associated with the disease. And these include stigma, adherence, injustices, and many more. At Reach Out Umbia, we focus on improving the livelihoods of elderly women, that is 50 years and above, living with HIV, to live a responsible and dignified life for themselves as well as the orphans and vulnerable children in their care. We do this through a holistic mode of care approach that takes care of the whole body, that includes the body itself, the mind, the family, and the community. Under these four components, on the body, we offer a comprehensive health package that involves screening and treatment of non-communicable diseases. Under the mind, we have addressed HIV-based vulnerability through increasing psychosocial support, legal, social protection, and we also advocate for rights and justice for this particular population. Through their families or under their families, we also focus on sanitation, nutrition support, economic empowerment, and supporting OVCs and young and teenage mothers in form of offering to them vocational and apprenticeship skills. Through their communities, we have developed a system of grandmother to grandmother model. In this system, a grandmother helps or reaches out to another grandmother in support to give comprehensive kind of psychosocial support and a linkage system. We also have a robust surveillance system of grandmother village committees. This is a team of grandmothers who reach out to different grandmothers to offer basic support such as linkage, such as follow-up, and revert the information back to the health facilities. This is used in monitoring and capturing of emerging issues throughout the communities our elderly population live in. Uniquely, we have modified HIV care services among the elderly and we've achieved a number of successes. Only 3 out of the 103 grandmothers screened for cervical cancer were positive. 634 elderly women were active on ART and were virally suppressed. We've also gone ahead to provide economic strengthening and handouts to the elderly in their communities through village saving schemes and financial incentives to enhance their financial capabilities in their communities. 158 young and teenage mothers received vocation and apprenticeship skills, and through our grandmother to grandmother support systems and communities, we have been able to track and monitor health outcomes of the elderly in their communities. 6 legal cases have been addressed to support grandmothers' rights and injustices. 6 community dialogue meetings with key stakeholders on grandmothers' rights have been held. 11 community sensitization outreaches have been carried out for the purposes of advocacy. With these achievements, we've learned a number of lessons we want to share with you. First of all, I would like to notify you that elderly-driven strategies have increased responsiveness and demand creation for HIV services. ART therapy among the elderly women requires harmonized efforts from different stakeholders that include healthcare providers, especially clinicians, nutritionists, expert clients, counselors, and family support to enhance adherence and viral suppression. It is to your notice that special attention is required to address drug interactions from multiple drug use among the elderly. Social and cultural values take precedence over art treatment in the elderly women. Aging comes with vulnerability. This is one thing we need to understand when we are dealing with the elderly population. Poor feeding is very common among the elderly in Uganda. The majority of the elderly are not prepared for the old age, and it takes a human understanding to work with this kind of population. In conclusion, HIV treatment in elderly women has been challenged with a number of physical, clinical, and social aspects. We therefore recommend all individuals and stakeholders to design special geriatric programs and interventions across all HIV spheres. We are looking at a community free of the spread of HIV, where those individuals already affected and infected by HIV are living positively with improved quality of life. Thank you.
Experiences engaging in a group-based physiotherapist-led exercise program for adults living with HIV and complex multimorbidity. People living with HIV are living longer and aging with HIV and the health-related implications. While exercise can be an effective self-management strategy to mitigate disability, few adults living with HIV achieve recommended physical activity guidelines. An HIV specialty facility in Toronto launched a group-based physiotherapist-led exercise program as part of its Stay Health program. The purpose of our study was to explore experiences engaging in a 12-week group-based physiotherapist-led exercise program from the perspective of adults living with HIV and complex multimorbidity. Specific objectives were to explore reasons for engaging in the program, perceived facilitators and barriers to participation, levels of exercise engagement over time, and perceived changes and impacts of participation on health and disability. We conducted a qualitative descriptive study using semi-structured interviews. We interviewed 8 men and 2 women living with HIV. The median age was 58 years, and participants had a median of 6 concurrent health conditions in addition to HIV, the most common being mental health and cardiovascular conditions. Participants described their experiences in the group-based PT-led exercise program, which spanned their perspectives prior to engaging in the program, during the program, and after the program. Reasons for engaging included the fact that the program was perceived to mitigate barriers to exercise that participants had previously experienced when exercising in traditional environments. Participants described extrinsic barriers, such as inaccessible facilities and stigma in the community, and intrinsic barriers, such as discomfort in conventional gyms due to previous negative experiences, lack of exercise knowledge, social isolation, and lack of motivation that had influenced their levels of exercise and physical activity prior to joining the program. Additionally, all participants described health-related goals for engaging in the program. Physical health goals were most common and included managing concurrent health conditions, managing pain, remaining mobile and independent with age, living longer, and improving fitness. Factors that positively influenced participants' engagement in the group-based PT-led exercise program included the following environmental factors: financial and physical accessibility of the program, such as the cost-free nature, as well as the elevator in the building, the warm and welcoming exercise environment, the supportive group environment, which was described as non-judgmental, the safety and supervision by the interprofessional program leaders with HIV-specific knowledge, the tailoring of exercises to individual needs or modifying based on fitness level, and flexibility of the program with episodic health challenges, as participants could make up for missed classes easily. Some challenges to engagement included poor weather conditions, long travel times, episodic health challenges, occasional overcrowding of the small gym space, and different personalities within the class. Participants perceived that engagement in the exercise program positively influenced their perceived level of disability in one or more domains. Participants also reported increased activity levels and felt more able to engage in exercise and physical activity. For physical health, this included improved fitness in several domains, as well as decreased symptoms such as pain and fatigue. For mental health, the program helped to manage mental emotional symptoms such as anxiety or depression and contributed to a positive mood overall. For social health, most participants noted increased social inclusion as they met new people and developed friendships. They frequently emphasized the importance of being part of the community as many had felt socially isolated in the past. And for cognitive health, participants reported greater clarity of thought and improved concentration. Participants reported that the program leaders actively encouraged them to strive for independent exercise, taking an active role in finding other accessible gyms and attempting to gradually decrease participants' reliance on the program. They also mentioned that having increased exercise knowledge and self-efficacy would make them more comfortable exercising outside of the program. Before enrolling in the program, participants perceived barriers to exercise, and some participants stated that some of these same barriers will make for a difficult transition to independent exercise. Commonly reported concerns included a lack of motivation to exercise alone, financial barriers, and discomfort in public gyms. Future exercise programs for people living with HIV should consider establishing an environment that mitigates physical and financial barriers, fostering a social environment that promotes a sense of community, having a flexible schedule to accommodate health fluctuations, tailoring engagement in exercise and physical activity towards individual goals, and employing interprofessional instructors with HIV-specific knowledge if it is feasible. Community-based exercise programs that are group-based and physiotherapist-led can facilitate engagement in exercise and physical activity among people living with HIV and complex multimorbidity. Participants perceived that the interprofessional team in an HIV-specific facility providing tailored exercise to a group of adults with similar conditions mitigated barriers to exercise and enabled participants to meet their goals around physical, mental, emotional, and social health and function.